Welcome to the Neural Implant Podcast, where we talk with the people behind the current events and breakthroughs in brain implants in an understandable way, helping bring together various fields involved in neuroprosthetics. Here is your host, Ladin Yurachek.
Hello, everyone. Welcome to the Neural Implant Podcast. Today's guest is Dr. Jack Gelman and Dr. Brock Lindsey of West Virginia University, and they are both surgeons, basically implementing neural implants into the nervous system. Dr. Lindsey is more on the osseo side, basically integrating it into the bone and into the body, and Dr. Gelman is more on the neural side, integrating the nerves. And so, yeah, guys, thanks so much for coming on. And West Virginia University, you guys are the first people to from this institution to be on the show. So yeah, take me home, guys. Take me home to West Virginia. Dr. Lindsey, do you want to introduce yourself a little bit, and then we'll go to Dr. Gelman?
Sure. So my name's Brock Lindsey. So I'm an orthopedic oncologist by trade. So it's an orthopedic surgeon that deals with bone and muscle tumors. I had an interest in amputation care quite some time ago, about 15 to 17 years ago now, as I look back. And I got into osseointegration through a gentleman named Rickard Brandemark, who was really one of the forerunners of osseointegration. And since then, I've been doing some research within it and also dealing with a lot of the complications that come along with amputated care. And that's kind of how I got involved with Jack Gelman as far as doing targeted muscle reinnervation work. And now we've created an amputation clinic where we have multidisciplinary faculty, including plastic surgery with Dr. Gelman, orthopedics with me for osseointegration, and then a physical medicine and rehabilitation doctor, Dr. Bethany Hans. So.
Yeah, and I'm Jack Gelman. I'm a plastic surgeon by trade. I trained as a general surgeon. That's how we used to do it. It was 5 years general surgery, then plastic surgery, and then I did an upper extremity fellowship. And it was during then that I got interested in peripheral nerve surgery. I have a varied practice, and I was brought to WVU. Part of my job was to be a hand surgeon here, but they had wanted me to start doing transplants, someone who had their arm amputated and transplanted. And I talked to a daughter of mine who's a biomedical and electrical engineer who's at the cutting edge of computer brain interface. And she said the future is not going to be putting cadaver arms on people, but rather using, cyborg type thing, robot arms, which then I talked with Dr. Lindsey, decided to start doing this. The targeted muscle reinnervation is what controls these robot arms right now. They're not controlled centrally. They aren't yet using the motor cortex of the brain. But this way, we use the patient's own nerves to stimulate muscles that you can put sensors on the skin. To make that work better, the osseo-integrated implants Dr. Lindsey's doing will make it much easier to hold on those robotic things. They only have those for upper extremities. There are not any commercially available right now for the lower extremity, for above the knee and below the knee amputations, but we're working on that. And that's one of the areas we're going to be doing research on. But we do all types of amputations, whether we're doing them at the shoulder, which is called a shoulder disarticulation. We do a transhumeral, which is in the middle of the upper arm, transradial, which is in the middle of the forearm, or we can do above the knee and below the knee amputations. So all of those, we can get prostheses and get right now just upper extremity that are robotically controlled through TMR.
Interesting. Actually, I didn't know about the cadaver arms thing. So how would that work? You'd have a cadaver arm, you'd have a dead arm, and would you be able to move that? I mean, you'd be reinnervating it, and it would be functional, or how would that work? Or would it just be kind of like almost like a prosthetic?
Yeah, it's a functional arm. I mean, they've done 100 of them worldwide. The surgery sounds complicated, but for a hand surgeon, if you're doing it at the level of the humerus, the upper arm, I mean, the blood vessels are big, the nerves are big, it's easier to attach. If you're in the forearm, just attaching the tendons so that they move because the nerves are still there. And they work pretty well. I mean, the hands open and close. There's been a couple that have had both arms done, some people, but, it's still a cadaver arm. You're on immunosuppression for life. There's risks of, problems with that, where a robot arm, if it breaks, you just buy a new robot arm.
Yeah, that's true. But the robot arms can be expensive. I heard about they could be about $100,000, and you can go through a few per year. Luckily, insurance or the VA covers that most of the time. So I guess, Dr. Lindsey, you're very much focusing on osseointegrated, basically making sure that it's connected to the bone. What are the advantages of that, and what are some of the challenges in this?
Yeah, I mean, I think several advantages. One is basically the ability to anchor a heavy prosthesis is first and foremost, especially in the upper extremity. Historically, a lot of these prostheses were quite heavy, and to be able to hold them on without slipping and pulling off the extremity was quite difficult. So one, giving them a solid foundation for which the prosthetics can combine to. So that's one. Two is it increases the lever arm of the extremity. So meaning that, depending on how much bone you have left, the implant goes into the bone and then you get the entire lever arm of the bone itself. So functionally, it's a much more powerful way to move the extremity, whether it be upper or lower extremity. The other portion is you get what's called osseoperception, where the patient gets a sense of where the prosthetic is in space because it's actually physically connected to them. So historically, you don't get as much of that sensation because it's not fully connected to the person. So their foot would catch on something or their arm would catch on a door and they wouldn't really know it was happening. And so that leads to some issues. Multiple other benefits, but those are probably the biggest ones as far as creating an osseointegrated prosthesis. Then it goes further into gait, gets better and time to up and go. The other real benefit that people talk about is no socket wear issues, right? So historically, we would have these, rubber or neoprene sleeves, and then those go down into a plastic socket. Patients have a ton of blistering that occurs, pain at the residual limb end, sweating. Some people have had their prosthetics fall off because of that, as well as when patient loses weight or gains weight, their socket then no longer fits. It's either too loose or too tight. And so they have to go through multiple iterations of these. And like I said, sometimes they even have wounds that require surgery. So it can be quite difficult. All of those go away with an osseointegrated prosthesis. There's no socket at all. The prosthesis doesn't even touch the skin. And what we call donning and doffing a prosthetic goes from what could be multiple minutes to even 15 to 20 minutes, all the way to probably 30 seconds of taking a prosthetic on and off. So getting up to use the bathroom in the middle of the night is a lot easier. You just use a bicycle clamp and hook it to your prosthetic right away and get up and walk. So lots of advantageous reasons to get rid of the socket. For AKs, so above the knee amputees, the socket actually sits, and a lot of them are ischial bearing. Ischium is the butt bone. And so when they sit down in a chair, that can be quite uncomfortable, especially for long periods of time, which again, they no longer have to deal with those kind of issues.
Okay. And yeah, that's really interesting. And then what are some, so I've seen this actually, osseo integrated devices, and they do seem much better and stable and kind of what you were saying, like it doesn't move. So you know where to predict, the body knows where to predict where that limb is. So yeah, what are some challenges to doing this?
I think a couple of the biggest challenges, obviously you have a transcutaneous component, right? So you've got metal that is basically coming through the skin and creating a stable stoma or area where that metal is coming through the skin, and the appropriate hygiene to make sure it doesn't get infected, right? So that's probably the number one most challenging component of it. Several of these devices have been around for quite some time in Europe and other parts of the world. And so we have some data to suggest that this works really well when done appropriately with appropriate surgical technique and appropriate hygiene. So you have to take care of this on the regular basis. So that's probably the biggest component. And then the second part of it is, the bone quality. Some patients that have been amputees for quite some time get what's called disuse osteopenia, where the bone becomes a little bit more fragile. So one of the benefits of an osseointegrated device is that you could potentially improve upon that osteopenia by actually mechanically loading the bone again. However, that doesn't happen right away. And so when you're going to implant the prosthetic, you've got to be very careful not to fracture or break or the like. So I mean, getting the osseointegrated device in tight enough or appropriate enough that the bone doesn't fracture, but yet at the same time, it also integrates.
Yeah, that's really interesting. I guess that's similar to what happens to astronauts if they're in space for too long. And so you guys were saying that the upper limb is currently, in practice, but the lower limbs are not. Is there a reason? Is it just because there's more load bearing force on it, or what exactly is the reason for that?
Actually, for osseointegration specifically, the FDA finally got approval for above the knee amputees right now. That's the only approval in the United States for an osseointegrated device. The prosthetics, however, for using targeted muscle reinnervation and basically a bionic arm that uses those sensors transcutaneously to fire the upper extremity, that's where prosthetics is kind of being utilized right now clinically. There are the ability to do it in the lower extremity. There just hasn't been as much research there. But for OI, the current FDA approval is actually only in above the knee. And we're trying to get some compassionate use and other ways to do it for BKs or transradials or transhumerals. And the FDA has been a lot more open to that recently, especially because of a lot of our veterans that have been injured and have amputations.
Okay, interesting. And so, okay, so once you get these devices, as you're implanting these devices, first of all, what kind of devices are they? How do you integrate them with the nerves? And then I think before we started recording, we were talking about gait analysis and improving gait. So how does this work? How does the device improve the gait?
Well, multiple ways. I think that it depends multifactorial, just like anything else in life. For the osseointegrated component and how it affects gait, obviously you're able to power the prosthesis better. You have a stronger foundation, and you don't have the socket wear problems where it's twisting or moving. So it's just a much more solid interface. So that allows you to gait and ambulate and walk better. Same with, time to get up and go, meaning going from a sitting to a standing position. So both those things should improve quite substantially with an OI device. However, with the targeted muscle reinnervation component, that helps with residual limb pain and phantom limb discomfort, which sometimes can be quite difficult when you're wearing a socket if you have neuroma formation or phantom limb pain. And Jack could probably talk a little bit more eloquently than I can about that. So that also, we believe, theoretically will help gait, which is part of what our research is saying, hey, how much does just targeted muscle reinnervation versus OI versus a combination of both, how much does that improve gait from both a pain perspective as well as a biomechanical perspective? And then to get the transcutaneous EMG sensors to be able to power a prosthesis, that's where Jack was talking about. We don't really have a lower extremity version of that like we do with the upper extremity. And so some of our research hopefully is to get into the lower extremity for those types of devices.
Yeah, Dr. Gelman, do you want to talk about the integration with the nerves and the devices used and everything?
Absolutely. So TMR, which is a lot easier to say than the whole word, which is targeted muscle reinnervation. So we take a muscle that we target and we put a new nerve to it. So we sort of call this the Daphne to Tata anastomosis because I have a big English Mastiff named Daphne, and one of the residents has a tiny little Yorkie named Tata, and we are taking a big nerve and we're putting it into a tiny little nerve. So what the problem was with amputees, whether above the arm, upper extremity or lower extremity, but especially we're working a lot with these lower extremity amputees, where if they cut the nerves and they take the nerves, you cut them, let them retract and hope the nerves are just fine. And then a lot of times they don't. They have three different problems that can happen. One is that they can get phantom limb. So everybody has phantom limb sensation. They might feel like their foot's there, but these patients have been telling us it feels like their foot's in a bucket of water and you put a car battery to it. Like it's that horrible pain. So, and it can come on suddenly. They can be asleep. It wakes them up. The other thing they have is, which Dr. Lindsey talked about, is neuromas. So the nerve will continue to regenerate. Nerves are sort of like lizard tails. They'll keep growing. And if they have nowhere to grow to, they form this ball. And we've taken a number out the size of golf balls. So you can imagine, and that's right at the end of the stump, right where they're trying to put their prosthesis. So you can imagine having this painful nerve doing that. And then the third is just generalized stump pain. So by doing TMR, or target muscle reinnervation, we take all the nerves that are cut, and then we find little motor branches to some of the muscles, which aren't doing anything because they don't have a leg below them or an ankle that they used to move, the knee. And we take these larger nerves and put them in there. The nerves will continue to grow, but now they're into this target muscle. So since we've cut the small nerve that goes to it, the motor nerve, the larger nerve will grow into it. So instead of forming a neuroma or having phantom limb, since it powers a muscle now, instead of just sitting there doing nothing. And that's what Dr. Lindsey talked about. We can put sensors then on the outside of the skin and sense these muscles because the nerves still power them, but they're different nerves. So because of that, those sensors can now, the same muscles that used to extend your knee, say on above the knee amputation, or flex or rotate your ankle, they're there. And now we could attach those and then have a prosthetic that can do that. They've done that in the upper extremity. We've put them into say someone has their shoulder disarticulation, their arms off at the shoulder joint. We take the nerves that used to run down the whole arm to the fingers, to the biceps, the triceps, and we'll put them into the pectoralis major and minor, the chest muscles. Then we can put sensors on the chest and it'll move the robot arm. We're going to do that now with move the robot knee and the robot ankle, which means your foot moves in 6 different directions. You can imagine how much better you could walk if your foot worked like a foot instead of you just swinging your hip and hoping it swings out. That's why we're working with prosthetic companies, but there is no commercially available robot leg, but that would be heavy. You'd have a motor move your knee, a motor move your ankle in different directions. If we have the osseointegrated implant, then we can clamp that on. The bone, like Dr. Lindsey said, would sense when you're stepping down. You get some proprioception, knowing where your leg is in space with that. And we think gait would be tremendously improved. We are now doing targeted muscle reinnervation. Dr. Lindsey and I are doing it on just routine amputations. When he has to amputate someone for a sarcoma, a cancer, or if we have a traumatic amputation, we will do the TMR initially. But the big thing we've seen huge results are people who had amputees 5, 10 years ago who've had these chronic pains. They can't wear their prosthetic. They're not getting around. They can't work. We do this surgery either with or without osseointegration, and we're getting them back to work. They sleep through the night like it's completely changing their lives. We think this is the next stage on it. If they can also get OI as well as TMR, then you're combining the best of both worlds. And that's why we're working together on it. But we do all of the cases together. Even a revision, Dr. Lindsey will come in and he'll revise the amputee while I do the nerves.
Interesting. Yeah, it sounds like it calms down the body and the body has something to attach to. So basically, I guess these devices are just EMGs that listen to that connection, that the big nerve and the small nerve, and there doesn't have to be any nerve integration with that, right? It's basically it's just on the outside of a building or something listening in. Is that almost how it works?
Yeah, I mean, it's sensing. I sort of simplified it. It does sense. You train. So after we do this, they put sensors, whether it's on the leg or on the arm, whatever. And then you have a computer and you will have a computer arm or a computer leg that you will move. And it's still pattern recognition. So it's not like one-to-one. It's not like thinking, extend your arm, like, it's still pattern recognition. When we do an arm, say, we will separate the biceps into 2 heads and I'll put a piece of fat so you don't have cross signal. So it's all electrical type. So one of your bicep heads will think flex the arm, and the other biceps head will say, let's flex the wrist and squeeze the hand shut. The triceps will think extend the arm, and the other head of the triceps, because we've separated it, and reinnervated, will think extend the wrist and straighten the fingers. So once you learn how to do it, then you do a combination, and you might fire a little bicep and a little tricep to sort of control your hand in space. And it sounds really complicated, but the brain is a lot smarter than we are as technicians, just hooking nerves up. So the brain can just take it over, and they get amazing control over that. We've seen such amazing control with the upper extremity. We think you would be able to do the same thing with the lower extremity, and then people would walk almost completely naturally. Like they would not be able to tell the difference, would be our goal.
Wow, that's amazing. Yeah, I mean, both of you guys have actually been kind of suggesting that this is pretty standard. It's not very difficult. Is this something that's common, or is this something that only you guys can do? And then also maybe how many patients have you guys worked on in this way?
I mean, I wouldn't say that this is 100% standard of care yet, right? So I do believe that the field is kind of moving that general direction. I think there are multiple people, in the United States and the rest of the world that are doing something like this or in combination of it. I think doing it together collaboratively as a real amputation clinic that's multidisciplinary, I think those are more rare, but they do exist. So I believe that the field is going that direction for sure, where the hope is that for the care of these patients that, some form of peripheral nerve surgery, some form of osseointegration will be at least options for all of these patients moving forward. We still have a lot of research to do. We still have a lot of clinical trials that need done on both OI implants as well as prosthetic involvement. So I wouldn't say that, it's standard of care yet, but I think it's moving in that direction. And at a more rapid pace than historically.
Right. Yeah. So to give you an idea, I mean, we've just written a paper. It's going to, as reviewed, there's been 500 papers written on this, but like 400 of them have been written since 2020. So it's that cutting edge at this point. We're the only ones in West Virginia doing it. We've done 28. Okay. So there are not even centers in every state in this country, but a lot of the large centers will have someone. But again, we think this is the best way to do it as a joint group between orthopedics and plastics or whoever's doing peripheral nerve, and then it can move forward. It is still much easier to just do an above the knee or below the knee amputation without TMR and without osseointegration. We do think that if we can make this, and part of our paper is basically calling demystifying TMR. This doesn't have to be as complicated as it looks when you read these papers. And the fact that we were able to do it, with just the two of us sort of setting it up. And we also felt it's important to get physical medicine and rehabilitation. So we have a third member of the team, and she works with all the prosthetists. She works on, a lot of these people have been on long-term medications, to control their pain, and she can help wean them off of those medications, stop some of the spasms with the muscles. And we do think 10 years from now, if you did this podcast, this would be the standard of care. That's our hope. Not standard of care doesn't mean every single person would get it, but we would just have to get enough surgeons out there. Osseo-integrated implants are like dental implants. Years ago, everybody's like, oh my God, it was a huge deal. Now everybody thinks, oh, big deal, I got a dental implant.
Yeah, that's really cool. And so, okay, let's say you guys got unlimited funding and you could improve something. What would you focus your energies on, and what would you improve in order to improve the outcomes? And I guess we can start with Dr. Lindsey.
I think that if I had an unlimited budget, where would I go? I do think, and there is an implant out there that is going to take these neural connections and actually include them directly into the osseointegrated prosthetic. So essentially, then you have a plug and play kind of prosthetic. So I think long term, do I think that that's probably the direction it's going to go? I do. I think that, so I think from that perspective, and then the prosthetic side itself and the gait analysis and the walking models that are going to be able to take the electrical information and be able to create an extremity, whether it be upper or lower extremity, to be able to interface appropriately so that gait and function are optimized. So I think, if I had an unlimited budget right now, I would work and focus on doing nerve integration into the osseointegrated implants that then talk in a very refined manner to a robotic extremity, whether it be upper or lower, to maximize function. And essentially, you're building, the $6 million man or woman, right? So where you're able to recreate extremities at a high functioning level directly. So I think that's where I would dump my money right now if I had a war chest.
Dr. Gelman?
Yeah, so mine, very similar idea is that, to work with a team of engineers who could actually develop these prosthetics for the lower extremity that would do it. We can also try to perfect the upper extremity more, the one with the upper extremity to have better sensation, that you can feel things better so you don't crush a cup, without doing it. They do get some feedback, but where you would actually be able to feel. I think the future I would also get biomedical neuroengineers who would actually be, they've mapped the motor cortex in the brain where they would actually, and there's some companies that are already working at, but we would power these prostheses directly from the brain. So you would put the sensors in the brain, they would then connect to this osseointegrated implant where you plug and play, but you're plugging basically into your brain. So your brain is then functioning it. And I do think what I'm doing right now with the target muscle reinnervation, sort of a stepwise thing, using the nerves are right now connected to the brain, but they have nothing to do. So I'm using your own nerves to sort of power it. Even better would be to have a Bluetooth device where you just put it in the brain, whether you go through a blood vessel and do it from inside or you go directly, and then the brain does it. And basically, I'm not even necessary anymore. But I don't think you can get there without the talk. You need this step to figure out how to do it. I think it would be too hard to do it, to go from the brain to the prosthesis without this interim step. And this is obviously much easier. I'm looking right at the nerves, so I can do it right there, and I'm not fooling with the brain. That I don't think is as far off or as bizarre as people think. I mean, yes, they can get monkeys to play Pong, but this is, I think, a little more important if we get people to walk.
Yeah, for sure. This is actually really interesting what you just mentioned, because as we talked about before we started recording, I'm working in the peripheral nerve, doing device design and fabrication. And so I'm quite fond of this. And I think that's it's the better option, because basically you're plugging into a USB in a computer versus like going into the CPU and trying to figure out where to plug into. So you're saying there would be an advantage to going directly into the brain versus going into the peripheral nerve, and what would be the advantage of that?
Well, because then you could, if you had just a Bluetooth device, I could just take the nerves. I wouldn't have to make them functional. All I'd have to do is eliminate the pain. You wouldn't have to put transcutaneous sensors to try to sense. Your body wouldn't have to relearn how to move muscles to do that, and do pattern recognition, because your brain already knows how to do it. I mean, before your leg is amputated, your brain knew how to move your leg. So if we could just go back, the brain would not even know that this is a robot leg. It would be doing the exact same thing it would be doing for your own leg. And then because of this osseointegration, it would be able to get some sensation. We could then actually put sensors within the leg instead of just the bone. So the sensory cortex instead of the motor cortex, you would be able to sense that your foot is stepping on something. You would feel a pebble on your bare foot if you had sensors on the bottom. Obviously, you would have to fine tune it so it's not hypersensitive. But imagine how much better you would walk if you constantly were getting feedback directly to the brain. That's just a step a little too far right now. I think whether we're using TMR or using what you had talked about, putting sensors in that we can run through this osseointegrated implant, is the future.
Okay, very cool. Okay, guys. Well, I also wanted, before we finish up, I want to talk about WVU, because you guys, as I mentioned, are the first people from there. So do you want to talk a little bit about your institution, why you chose it, and maybe plug it for the rest of us? Dr. Lindsey?
Sure. I mean, I think I had the advantage of doing some training here initially, and then went away to do further training. So I kind of, for lack of a better way to think it, knew what this facility was about. I think that the substantial growth that's occurred at West Virginia University over the last, I would say, 5 to 10 years has been fantastic. I think the velocity of growth and change has been really fun to be a part of. I think that's part of the reason why I came back, is because I felt like I like being part of, high velocity change, if that makes sense. It's a fun place to be from that perspective, and it has, everything that a large academic facility would have, but still has that kind of hometown feel that you alluded to, which I also like.
Okay, Dr. Gelman.
And for me, it was different. I spent 25 years in private practice in Chicago, the big city type of thing. And then for me, it was a chance to give back. They had just started a plastic surgery residency, so I got to start with that, training residents. The catchment area for West Virginia is there's 1.8 million in the state, but we do some of the rural areas around parts of Maryland, Pennsylvania, Ohio. They are, again, this massive growth. I mean, the number of physicians they've added is tremendous. It went from 500 to 1,300 in like 5 years. I mean, it's at this asymptotic growth curve. But what I like is the research here, and it's all practically oriented. Like, they're not like, okay, we're not looking at something in a petri dish and let's figure out and because it's small enough, if we want to work with the engineers, we just call them up and they come over. If we want to go over to a lab, it's like, you don't get that same institutional thing. And everybody sort of has that idea of like, we're here to serve the people of West Virginia. I've lived in some other places, but this was one of the few states, probably the only state I went to, like, as soon as you're here, you're one of them. Like, when everybody calls you hun or whatever, but when they do, they really are acting like it. It's not like, okay, you're not really from here. They're like, okay, you're one of us now. We're glad you came here, which is a really refreshing thing. And it's beautiful. I live up in the mountains and have bought kayaks, do all that kind of stuff that people in West Virginia do.
Wow. Yeah, that's really cool. As we were talking about before the episode, one of the podcast previous guests moved there, Dr. Lauren Reith, and so he was telling me about it. And I hadn't heard that there was such a big neuro program there, but it makes sense if it's kind of a new thing, asymptotic growth, hockey stick growth. So that's really cool. So guys, thank you so much. Is there anything that we didn't talk about that you wanted to mention?
No, I really appreciate the time. I appreciate you having us.
Yeah, this was great.
Okay. Thank you.
Okay.
Hope you enjoyed the show and were able to learn something new, bringing together different fields in novel ways. Until next time on the Neural Implant Podcast.